Good evening, everyone. Today, my paper would be on correlation of clinical, biochemical, and echocardiographic parameters with outcomes in patients with pulmonary arterial hypertension. This was a single-center prospective and observational cohort study conducted in Triple M Hospital, Chennai. So, as we all know, PAH is a progressive disease which affects both the pulmonary vasculature and the heart, with the prognosis of patients relying solely on the right ventricular function. Failure of RV to adapt to this increased afterload ensures RV failure, which leads to mortality. Initially, these patients exhibit signs of RV failure in the form of reduced exercise capacity. Eventually, they do develop frank signs like hepatomegaly, ascites, bowel disturbances, gastroparesis, and renal failure. Acute increases in pulmonary vascular pressure with acute decrease of cardiac output clinically manifests as pre-syncope or even frank syncope symptoms. Eventually, these patients die of severely reduced cardiac output, arrhythmias, worsening of myocardial dysfunction from coronary hypoperfusion caused by elevated RV end diastolic pressure, LMCA compression, or from other reasons like pulmonary artery rupture. So, such a mal-adapted right.
Excuse me, can you go to the data? Can you go a bit fast? Can you go to the data, please?
Yeah, sure. Yeah. So our main aim was to correlate clinical signs, biomarkers, echocardiographic parameters like TAPC, RVGLS with the commonly used surrogate endpoints, namely the WHO functional status and 6-minute walk distance, along with hard clinical outcomes such as hospitalization and death in our cohort of patients. Study setting, Triple M Chennai, December 2019 to 21, a total period of 24 months. So study sample, our total cohort included like patients who belong to group 1 PAH. Inclusion criteria: subjects who are aged more than 1 year with an established diagnosis of pre-capillary PH with mean pulmonary artery pressures of more than 20 and PVRA of more than 3. Who are excluded? Patients belonging to group 1.4.4, that is congenital heart diseases, and 1.7, that is PPHM. Presence of significant arrhythmias or presence of significant lung disease or infection were excluded from the study. So we collected all the parameters like clinical examination details, biochemical test, 6-minute walk distance, blood samples for gene analysis and biochemical parameters, ECG, X-ray, and cardiac cath as and when required. The data was collected like this, that is the baseline data, the first visit data, and the first visit which was at 12 months, the second visit which was planned at 24 months. The main endpoint studied was the composite of hospitalization or all-cause mortality through 24 months. Surrogate outcomes studied were WHO functional class and 6-minute walk distance. So data analysis, p-value less than 0.05 was considered statistically significant. We mainly used correlation analysis and Cox proportional hazards regression to assess the correlation between the various variables and the outcomes. This was the study plan: 68 patients, first year, no mortality, second year, 9 mortality, no patients were lost to follow up, and every visit they underwent all the biochemical parameters, clinical examination, chest X-ray, and ECG. Cath was decided in case-to-case basis. This was a subcategory of 6 patients were in connective tissue disorder group. So how did the WHO functional class change? This actually indicates the betterment of the cohort in whole. Like WHO class 2 increased to 94%, while there were no patients in class 3 and class 4 at the end of the study. Class 1, which was not present at the baseline, increased to 5.1%. So diagnosis in expired patients, that is a total of 9 patients. 4 patients belong to IPH AFR. 1 patient belonged to familial PAH with AFR. 1 patient was post-BAS. The rest of the patients did not have any palliation. So this was a pie chart showing the palliative procedures which was done in our cohort. Around 31 patients underwent AFR and around 4 patients underwent a BAS. No palliation was done in 29 patients. So this tabular column shows the entire baseline, first follow-up and second follow-up characteristics. I'll just highlight the important points in this. The major things, we didn't find any clinical significance except for NT-proBNP and 6-minute walk distance. This actually changed, and the p-values we got was less than 0.05. As you can see, the mean values decreased from 1,200 to 950 to 372, indicating the overall betterment of the cohort on treatment. 6-minute walk distance improved from 334 to 334 mean to 354 to 371. again indicating that these two are statistically significant out of the entire variables analyzed. Echo variables analyzed, IVC congestion was of more than defined as more than 21 millimeter. Again, decreased from 29 to 9, which was statistically significant. RVS prime again was statistically significant. RVSP decreased as we followed up the patients from 91 to 84 mean, which was also significant. So RA diameter and RV mid cavity diameter also decreased. All these were statistically significant. The other parameters which we analyzed was PAT, which also showed improvement from 76 to 82, while RV free wall strain, RV FAC and TAPC all were statistically, the changes were statistically significant, indicating the betterment of the cohort. So now we took all these echo parameters, we correlated with these 4 outcomes which I mentioned earlier, and we saw what was actually significant. So I put the main important points here. Pre-syncope was a commoner symptom reported by patients belonging to functional class 3 and 4, with pre-syncope being common in patients with 6-minute walk distance of less than 330 meters. In the expired group, 8 out of 9 patients had pre-syncope, indicating that pre-syncope was much more common in the expired group and was common in patients with all-cause hospitalization. And pericardial effusion was common in patients belonging to functional class 3 and 4, and in patients with all-cause hospitalization. 7 out of 9 patients who had expired had pericardial effusion. Sorry. In patients with 6-minute walk distance of less than 330 meters, pericardial effusion was a much more commoner finding. All these differences were statistically significant. And we correlated 6-minute walk distance with various echo parameters. The results were positive correlation of TAPC, right ventricular free wall strain, right ventricular FAC, left ventricular global longitudinal strain, and right ventricular S prime, which all correlated positively with 6-minute walk distance, while right ventricular systolic pressure and NT-proBNP, as expected, had a negative correlation. So this was the hazard ratio of various parameters with the event of death. So again, this analysis showed NT-proBNP and RV free wall strain had the best correlation with the p-value of less than 0.05 with the event of death. So analysis of mortality, out of the 9 expired patients, 5 patients had received atrial flow regulators, out of which 2 patients died within 7 days of implantation. These 2 patients with early mortality actually had a revealed score of 18 and 16 points, indicating high risk patients with poor prognosis. 4 deaths, other 4 deaths were sudden cardiac deaths. 2 of them had severe chest pain and died en route to hospital, possibility of LMCA compression or pulmonary artery dissection or rupture. Cause of deaths in other 3 patients remain uncertain, could probably be due to arrhythmias. A Kaplan-Meier curve showing the entire cohort, showing that all deaths happened after 12 months, with 9 deaths in the second year of the study. So here I've compiled all the parameters with the 4 outcomes. So RV free fractional area change had a significant correlation with 6-minute walk distance, while TAPC did not correlate with mortality, but correlated well with 6-minute walk distance, WHO functional class, and hospitalization. PAT correlated only with 6-minute walk distance. The best parameters analyzed NT-proBNP.
Ram, you have 1 more minute.
Yes. So the recommendations from our study are echocardiographic RV variables being non-invasive tools help in diagnosing, prognosticating, and predicting PH patients. Our study recommends the use of RV free wall strain and TAPC in predicting the surrogate and the hard outcomes. Presence of pericardial effusion, presence of pre-syncope are vital history and echocardiographic findings to be taken into account. In view of, even though our speckle tracking RV free wall strain had a good correlation, due to changes in speckle tracking software algorithm between machines and between different vendors, this, even though being a very good parameter, might have some fallacy. Serial NT-proBNP monitoring is also a useful tool in predicting the worsening of RV function. Limitations, as I told, quantifying RV morphology may vary between echocardiographers and machines, and RV free wall strain by speckle tracking might also vary between vendor to vendor. So these are my references.